Hello, my name is Charlotte Pawlyn. I'm a clinical research fellow from the Institute of Cancer Research and the Royal Marsden Hospital in London. I'm here at ASCO 2014 to present some initial results of Myeloma XI. My abstract title was Optimising Induction and Pre-Transplant Consolidation for Myeloma, Results of Myeloma XI, a phase 3 trial comparing different IMiDs. Myeloma XI is a large randomised phase 3 trial for newly diagnosed myeloma patients of all ages. It was run across over 100 centres in the UK and recruited over 2,000 patients. From previous studies, we know that both immunomodulatory agents, thalidomide and lenalidomide, are effective as induction treatments for myeloma. We also know that novel agents are most effective when given in combination regimens. We therefore designed a trial to compare outcomes with the different IMiDs when given in combination with cyclophosphamide and dexamethasone. Patients were randomised between the two treatments and treated to maximum response or intolerance. Attaining a good response to induction treatment has been suggested to predict for better long-term outcomes. And so for patients who had a suboptimal response to their initial induction immunomodulatory agent, there was a second randomisation between receiving further consolidation with a proteasome inhibitor triplet or no further treatment prior to going on to autologous stem cell transplant for those who were eligible. For all patients, both transplant eligible and non-eligible, there was then a subsequent randomisation for maintenance between lenalidomide and vorinostat, and no maintenance. The results I presented on Friday were the first analysis of patients' response comparing the IMiDs at the end of initial induction. Both groups were well balanced in terms of patient characteristics, and both groups tolerated treatment well. There was a difference in terms of side effects, which we would expect with the different treatments, with thalidomide causing more constipation and peripheral neuropathy, whereas patients on lenalidomide tended to have higher rates of cytopenias. The results showed that the overall response rates with both regimens were high. When the trial was analysed as a whole, there was a statistically significant difference in our planned comparison between combined complete response and very good partial response, favouring lenalidomide. When we examine the results in detail, we can see that the biggest difference seems to be in complete response rate, with an almost 10% higher rate of complete response for those patients who received lenalidomide rather than thalidomide. This pattern was seen for both the younger, fitter patients who were transplant eligible and the older, less fit patients who were not going to go on and receive an autologous stem cell transplant. This suggests that patients treated with lenalidomide rather than thalidomide gained a deeper response, and we're waiting for a longer period of follow-up to see whether this will transfer into a prolonged progression-free and overall survival. I also presented some results looking at the use of sequential proteasome inhibitors for those patients who did not have a response of at least a very good partial response to their induction treatment and went on to receive the bortezomib triplet. This analysis showed that the use of sequential proteasome inhibitors can improve response in 50% of patients, although again we need to wait for survival data to see how this translates into improved progression-free or overall survival. The question of whether or not using immunomodulatory agents and proteasome inhibitors in sequence rather than in combination, the latter is being often done in the United States, is addressed in our follow-on study Myeloma XI+, which compares the sequential approach to a quadruplet induction regimen, including both an IMiD, lenalidomide, and a proteasome inhibitor, carfilzomib. We are currently analysing the biological samples for the large number of patients in the trial, and the results of this, along with further data around response and survival for the various parts of the trial, will hopefully provide exciting new insights into the management of myeloma over the next few years.